Thank you very much. Thanks to the people who are here. Hopefully a few more will straggle in. Let me know if this is too loud and we can turn the microphone down. Life imitates art, and we go to the Vascular Anomalies Clinic and we look at a lot of images and then we actually meet the patient. We're going to go over the clinical imaging and then we're going to talk about vascular malformations. But I've put it in the framework of the ISSVA classification that you're already becoming very familiar with. So I think you'll see this is kind of an introduction to vascular anomalies that will set the stage for the presentations that follow. You've been getting vascular embryology sort of in spades today, and the point I want to make here is this polarization at embryology day 9.5, I always thought it was day 9, now I know it's day 9.5, that sets the stage for this sort of budding off and creation of the lymph sacs in this vasculogenesis phase and then followed by angiogenesis, I think contributes to the spectrum of lymphatic orders that we see, because I think depending on how early this happens, you may see more lymph, you may see conducting issues, you may see just sacs and the fluid-filled sacs. And so I think the morphology kind of reflects where along this developmental process the hits occur. As has been pointed out, these lymphatic sacs generally form in a more robust fashion, kind of at the cranial cephalad aspect of the embryo, and I think that is fitting with the fact that 75% of them we see in the head and neck and torso, and then elsewhere, of course, throughout the body as things spread out, but that all makes sense. This is an infant with a obvious mass in the axilla. MR imaging, and we'll talk about imaging more carefully in a moment, but clearly sheds light that this isn't simply a big mass, it's largely large fluid-filled sacs. And then if you look at the histology, it is an abundance of lymphoid tissue with these large sort of stellate sinusoids. You're all now very familiar with the D240 stain, antibody to potoplanin, which is specific to lymph. So this slide would look a lot like a venous malformation if it wasn't for this particular staining, and that's a very helpful tool. I'm not going to spend time in these syndromes, but just to be thorough, lymphatic malformations do occur in association with other anomalies and may be a prominent feature of it. I really want to talk about the sort of more simple lymphatic malformations in this talk. As has been pointed out to you before, this is an online resource from ISSVA, and you can see the genetics where it is the molecular mechanisms and gene issues have been uncovered. So I'm going to just go through this list kind of in stepwise fashion. We talked a little bit about the treatment of the common macro and microcystic lymphatic malformations earlier today, and I'm going to make a few more comments on those before we move on to the more some of the more esoteric things, although in the in earlier presentations today you've actually been introduced to a number of these concepts, so they won't be so foreign. So let's look at the macro versus microcystic. That's a convention that really is a sort of a size criterion of convenience. It's really for the people who are thinking about treating these by injection of a sclerosing agent. It's really a sort of a practical cutoff. Can I put a needle in, suck fluid out, and replace it with whatever agent I want to use? It's not microscopic and you can't see it versus macroscopic. It's really sort of a more practical cutoff. Here's an obvious large malformation involving the whole shoulder, often referred to as cystic hygroma. You'll see lymphangioma. Again, we're trying to get away from the oma terms because that sort of implies tumors and proliferation, and these really aren't proliferative lesions in contradistinction to the tumors. And then this frog spawn or fish spawn or lymphangioma circumscriptum, these small vesicles here, they're not going to be drainable or sclerosable, and so you have to look for other means of treating them. I've referred to this chart a couple of times in general for vascular malformations, but also we'll say a few more words about the slow flow malformations. And this is sort of the dichotomy that I use, and I've heard others using it too. And I like it because slow flow is kind of one set of tools, how we treat these, and then high flow we're really dealing with in an entirely different fashion. And in the slow flow malformations, the way to distinguish between the venous and lymphatics typically have to do with the morphology. Lymphatics tend to be cysts of varying sizes. The venous malformations are sort of tubules kind of organized in a knot of varying sizes. And then if you look at excuse me, the enhancement pattern, you may see in the venous malformation, or should see, sort of uniform lighting up bright as a light bulb, since those channels are in communication with the vascular space, whereas the lymphatic cysts tend to be excluded from that compartment, so the septa may enhance, but you don't really see the fluid-filled spaces, and a lot of times there's significant overlap. And then, as I mentioned, there really shouldn't be a mass with these lesions, although you do see fat hypertrophy or soft tissue hypertrophy in a number of them, and so that can be a little confusing, but it's really to distinguish, is the mass sort of the prominent feature, because that's going to tell you if you're really looking at a hemangioma, which has high flow, but there's a clear mass involved, and an AVM where you really don't see a mass. So here's a nice clinical example of a presentation of an abdominal cystic, macrocystic lymphatic malformation. You can see ultrasound is a great start for these, especially in kids, but further imaging is usually pursued. This is very helpful because in contrast to the fluid-filled cysts anteriorly, you see this posterior cyst or two with high-density material in it, and that's blood, and that's why this patient presented, because these either typically present with an enlargement and pain due to spontaneous hemorrhage or infection. So not only have we kind of zeroed in on the diagnosis, we also have a nice explanation for why the symptoms have occurred. So we'll go back to that case in a minute, but I want to just talk about imaging in general of lymphatic malformations. This was a nice article on vascular malformations in radiographics a few years ago. T1, T2, and post-contrast imaging. And on T1, the lymphatic malformations tend to be iso-intense with muscle. You may see large, what look like cysts. You may see clusters of grapes. On T2 imaging, the fluid should become bright. This is a little bit mixed, but you can see some bright areas. And then, as I mentioned, the septa may enhance, but the fluid itself shouldn't. So after contrast administration on this axial image, you do see bright foci. And so this is probably a mixture of lymphatic and venous malformations, because there really shouldn't be enhancement of those cystic spaces. This is the CT of the child that you saw before. Again, you can see high-density material in a couple of the cysts, indicating large hemorrhage. They placed a drain in this, and then they got a follow-up MR 6 months later. You can't even really tell where it was. These are often found incidentally, and typically they can get pretty big, and they don't usually cause symptoms. Like we'll not infrequently encounter these kind of lesions. The surgeons don't usually touch these because they typically, are incidentalomas. But occasionally they do present with pain, and then when you drain them and sclerose them, they seem to respond. So here's a placement. This is that same paper and a different patient in that same paper. And here the drain has been placed, and then follow up a year later, you again can't really tell where those macrocysts were. So these are real nice success stories, and I think this is where our successes lie, are in the macrocystic lymphatic malformations. The problem is that these are rarely purely large cysts, and they're often more complex. This is an interesting malformation. You can see that in this axial contrast-enhanced T1 weighted fat suppressed image, this large lesion here in the shoulder, it becomes much more conspicuous. On the coronal images, is a teenager who presented with pain. You see this large kind of stellate or cauliflower-looking lesion. It enhanced after contrast administration, and when we aspirated it, it was pure blood. But there's really no flow in this. There's no flow in, there's no outflow. I think this is really going to turn out to be a veno-lymphatic, maybe something that occurs really early in that embryogenesis of the lymphatic creation. Here we stuck needles in several places, creating a circuit, and I used alcohol, and you basically inject it in one location, aspirate it from another, do a series of lavages, and this actually did really well. Sometimes this is a good lesion to treat with the sodium tetradecyl sulfate foam, because you can really kind of push it into all the nooks and crannies as well. So the treatments are really kind of tailored to the lesions and outflow and whether or not you can trap the sclerosant, but then it's kind of dealer's choice. So moving on, I want to spend a little bit of time, but not a lot. Fran may talk more about this in a moment. And these are two sort of related issues that generalized lymphatic anomaly and Gorham-Stout disease, two related entities that you may or may not have really heard much about, but they're really fascinating, and what they taught me in medical school has nothing to do with the actual facts as we are now coming to learn them. For those of you who haven't heard the term generalized lymphatic anomaly, often referred to as GLA, this is the entity formerly known as lymphangiomatosis. It's, again, we're trying to get away from omas, but you see diffuse nodular deposits of lymphoid tissue. Dr. Roxon showed a whole limb that was affected by it. It has a predilection for bones, specifically ribs. And you see these punched out lesions, and I'll show you examples. And then Gorham-Stout disease, this is, I was taught that this was a lymphatic a venous malformation or a hemangioma, I think, when I was a resident. Now it's clearly lymphatic, plus or minus some venous tissue there. And for all intents and purposes, they affect the same areas, they do a lot of the same things, but the Boston Children's Group looked at the skeletal features of the two entities and really found some distinct differences. And we'll talk about those more in a second. Here's a nice example of these diffuse deposits of lymphoid tissue in GLA. Another patient here, the ribs are obviously quite abnormal. Then there's this large soft tissue mass posteriorly on this axial CT. Here's a sagittal MR showing, again, another massive sort of deposit of these lymphatic sinusoids, as well as tissue in the neural foramina here. And this is from that paper that described some differences, although I think it's really kind of an overlap syndrome. And here was a nice example of a progression over many years. And you can see that here are these bright foci in the vertebral bodies that some go away, some stay the same. But there is preservation of the cortex and the vertebral heights, so there's really no destruction here. It's kind of lymphatic tissue that permeates them. This is a nice example from a different paper, and it looks very similar to the case that Dr. Roxon showed earlier of massive progressive osteolysis or Gorham-Stout disease, where in this IV drug abuser, I think they thought this was going to turn out to be a septic hip. And the femoral head is gone, the femur is displaced up in this dysmorphic acetabulum. But as you can see from the axial and coronal CT in bone windows, there's all this soft tissue here occupying the joint space. And this was confirmed on a coronal MRI scan, where again, you see all this soft tissue. And it's very characteristic in these destructive bony lesions in Gorham-Stout to see lymphatic tissue kind of filling those destroyed areas and into the soft tissues surrounding. So it's a much more infiltrative process and characterized by the presence of soft tissue, which you don't see in the other. Moving on, earlier we heard a presentation about the channel type of lymphatic malformation. One of the earlier categorization of vascular anomalies talked about truncular and extratruncular. I don't think truncular is even in the dictionary, but you sort of know what it means. It's the conducting lymphatics or other vessels, and they're typically sort of central. They may be named structures in distinction to the peripheral ones. This is the subcategorization, so you can see these truncal anomalies can affect. Typically it's lymphatics, but you do see it also in arteries and veins as well, and then you further subclassify them. Here's a normal lymphangiogram. I realize this is uber small, but it's a collage of lymphangiograms that I've performed over the years, just to show you from stem to stern what a normal lymphangiogram should look like. Here's a cartoon I took off the internet, and you can see you start with these very fine angel hair sort of peripheral vessels, same thing in the upper extremity, and they kind of coalesce as you get to a sort of dense archipelago of lymph nodes in the groin, and you'll hear from Dr. Itkin, who does a lot of lymphangiography by direct access of the nodes. And then you'll see and in fact, it takes, as somebody alluded to this earlier, it doesn't take but, 10 minutes for the contrast to get from here to here. Although I am putting it through a pump, it's mainly because the needles are so small and the oily contrast is so dense, I simply can't physically inject it. And so we may be overwhelming the normal pumping mechanism, but it doesn't take very long to transit to the groin. And then what you see are these confluent chains that kind of parallel the great vessels. In the abdomen, you'll see a nodal chain on the lateral side of the vena cava, in between the cava and the aorta, and on the outside of the aorta. And you'll see that also in the pelvic vessels as well. And the reason I point out the cartoon here is a lot of times the lymphs are supposed to coalesce into a cisterna chyli, kind of a lagoon, a little lake of pooling, and then flow through the aortic hiatus and up the thoracic duct, as you see here on this cartoon. That's extremely variable, and the cisterna chyli in a lot of individuals is really very small and can be quite challenging to access, although if you wait a while, you will see accumulation of contrast. Sometimes you're not waiting very long during the lymphangiogram and things are kind of transiting by, and if you give it a little more time, it'll accumulate. But what I wanted to point out here, and it was in a very elegant cartoon that Dr. Roxon showed earlier, you really have a right and a left thoracic duct in a lot of people. And although typically there's a dominant left thoracic duct that goes up the spine on the left side and then plugs into the left subclavian vein, it's not uncommon to see branches going over to the right, or even a very mature looking thoracic duct. I've seen thoracic duct only on the right side, all the way up and plugging into the right subclavian vein. But it clearly explains why some patients will develop large chylous effusions after thoracic surgery on the right side only, and you're like, well, the thoracic duct's a mile away, how'd you hit that? And it's because they've gotten into one of these major trunks that exist there naturally. Here's a nice clinical example of a woman who, a referral from Dr. Roxon. In fact, the next 3 cases will be. Persistent chronic pleural effusions. This chest tube was placed. It drained really well for a while and then stopped, and the CT shows you that it's now becoming quite organized, and you can see some enhancement at the rim. And although we've had some discussion about whether this is proteinaceous fluid or not, it sure organizes very quickly, and we'll frequently use TPA or something to try to help break up some of this, or put in guide wires to kind of keep things draining or upsize the tube, just because they organize so fast sometimes. So here's her lymphangiogram, normal calf, and you're going to see a pattern here. Most of the times things are very normal peripherally, but then stuff starts happening. And as you can see, as we're getting up into the thighs, this is clearly not normal. The right side looks very normal. The left side is doing something peculiar. You see all these lymphatic cysts, and everything's obviously in communication, but I don't really know how the connections are all made here. And this bizarre architecture continues up. You see these little satellites of funny-looking vessels. You know, they're following the iliacs. They're kind of in the right area, but they're extremely numerous, far more than you usually see. Get up into the abdomen, you can kind of see that tripartite architecture that we talked about. And at this point, I want to make sure I've scouted up at the thoracic inlet, because a lot of times the transit really starts moving pretty quickly at this point, and you're not really filling a contrast column to the tippy top. And you want to be alert, because sometimes you'll get here and you go, wow, the contrast just sort of stalled. And then you go up to the shoulder and you see the upper part of the thoracic duct, and it's full of contrast, and things are quite well along. Here is stuff going off into the mediastinum, not really sure where that's going, almost like lamb, where you see lots of lymphatics kind of going in every direction. Here is a thoracic duct, though, and she does drain, and there's really no obstruction, and there's no leakage into the pleural space, so I'm not sure if it's just too slow to detect. We got a chest x-ray the next day, just wondering if we'd see a bunch of oily droplets in the chest. We did not. We see all these little foci of very dense contrast. That's the nice thing about the lipiodol. It's 37% iodine, so it is really easy to pick out just even little tiny droplets. But we didn't see any connection to the pleural space, but clearly there must be. This is another gentleman who was referred to me by Dr. Roxon, who had lower extremity lymphedema, but more impressively, massive scrotal lymphedema. And he had rigged up some compression device. I didn't see one for sale out there, but it was a very clever way of kind of keeping those tissues compressed because of the morbidity of it. You can see his leg compression's working very well, but we inject a blue, it's isosulfan blue, it's an indicator dye. It's very rapidly absorbed into the lymphatics. And in him, I wish I had taken a video, because this happened like while you watched. It just diffused through these dilated dermal lymphatics in this very lacy pattern. And then a little bit later, you see blue appearing in some of these kind of disorganized looking lymphatics. On the other side, the top of the foot did the same thing, but then we saw a nice blue streak going up, and we cannulated that. And so here we are on the left, and we see pretty normal looking ducts, although they have I don't know if these are, lymphangions or what they are, but they're very sort of beaded looking. I don't know if you can appreciate that all the way in the audience, but they're not smooth. And then when you get up to the thigh, there again you see that beading. Here we are seeing lymph nodes filling. We don't see anything going to the scrotum. That may even be the scrotum. And then here's disorderly, dysmorphic lymphatics going up into the abdomen. And by the time you get to the chest, there's a normal thoracic duct. Everything is draining. There's no obstruction. So my final example here is this person who had a really unusual condition that I hadn't encountered before, and that is she had lymphedema, chylous, but interestingly, she also opened up these vesicles, these small vesicles on the skin in her right thigh, and she would weep milky fluid for days on end, and then they would sort of dry up. And you can see, again, normal peripheral lymphatics. You get up to the knee, stuff is clearly not normal. By the time you get into the thigh, these are abnormal, and I'm assuming that these are kind of at the base of those weeping vesicles. By the time you get to the abdomen, things are really bizarre. Large cystic spaces, nothing following a normal branching pattern. Didn't really see much in the abdomen. The contrast just simply, sails up, and by the time you get to the chest, there's a normal thoracic duct and normal drainage. So again, we didn't see leakage into the abdomen. We didn't see obstruction to flow. The transit time was rapid, but these are clearly some kind of either generalized lymphatic disorder or a truncal type of defect that is hopefully we'll sort out one of these days. And that's the completion there. And then finally, a lot of the lymphatic malformations, you don't really use imaging in order to make the diagnosis. It's pretty apparent when you're looking at a port wine stain, what the problem is. And it's the same thing for lymphedema. But you do see the phenotype on a lot of the imaging studies that we do, and you may pick it up incidentally, or you may be looking for it. Way back, occasionally we would do a lymphangiogram for lymphedema. That was, it's progressed to stage 4. It's all rock hard. You can't really, sort it out clinically, although you certainly have a strong suspicion. And here's that lacy network of lymphatics, and hold that picture in your mind because you're going to see that again in the depiction by MR. I borrowed this from the internet because the one case of this that I have is from like 1992, and I don't have the films anymore. If we want to make the diagnosis of lymphedema, and occasionally this is clinically important, we typically use nuclear medicine. Sulfur colloid is injected in the web spaces of the toes, and you image over time, and you also put a region of interest and try to determine a transit time. And so you can see this is markedly abnormal. Here's this kind of sock distribution, boot distribution of the accumulation of radiotracer on the right side, and then there's clearly something happening in the inguinal region as well. And often you'll find that in primary lymphedema, the transit time is reduced as well. So I don't personally do this study, so I really don't have a lot more to offer, but let you know that that's a diagnostic tool. We don't usually do MR for this condition, but here's another example, a couple of examples that I borrowed from the internet, and you can see they really bear a striking resemblance to the lymphangiogram. These are all high resolution, very heavily T2 weighted. You may see other things as well, normal structures here, but all of these are in the very superficial soft tissues. And not infrequently, we'll be imaging patients with lymphedema. Typically, they're cancer patients. We're kind of doing a lymph node survey to follow up. But you'll see very characteristic enlargement of that limb, thickening of the skin. If you're giving contrast, everything is kind of enhancing. You can see all of the soft tissue septations are also sort of edematous and thick, and it looks sort of like anasarca of that limb. So again, we don't typically do it for this purpose, but you see this finding quite frequently, and if you see it in somebody who is not known to have lymphedema, you can certainly make that suggestion. So I want to just wrap it up by saying this was kind of a quick overview of the imaging of lymphatic malformations. I participate in a multidisciplinary vascular anomalies clinic, and a lot of places use that model, and it's extremely helpful. It was alluded to earlier. I'm an okay imager. I'm really an interventional radiologist, but our clinic starts with an hour-long review of all of the imaging by a neuroradiologist as well as a body radiologist or an MR specialist. We have plastics, derm, ENT, the whole gamut of people involved who have a lot of experience, and I think that really helps because very rarely do we see simple macrocystic lymphatic malformations, at least in our center. Most of the time they're complicated or they're combined lesions, they're mixed lesions. And so these really take a combined approach. And we are starting to investigate some of the medical therapies, well, specifically sildenafil and sirolimus, for treating those that are sort of being activated by sirolimus, the mTOR pathway. I'm not really sure what we're doing with sildenafil, increasing lymphatic motility, I guess, or contractility. But right now, looking at the imaging, I can't tell from that phenotype which genotype they have and who's going to respond to what. So there's a lot of work to be done in this area. If you find this stuff interesting and all the science, I think you would find that the ISFA meeting is really sort of the clearinghouse or sort of the focal point of research and clinical activities. It meets every other year in host country. Next spring it'll be in Buenos Aires. And I think the society's up to several hundred now, so it's a pretty small group of dedicated individuals, but It really, I think, has been at the forefront in terms of the classification of this mysterious mix of diseases, and is really a very active society of very diverse individuals and backgrounds, all focused in a single area. So it's a really nice sort of collegial environment, and I encourage you to join us in Buenos Aires next spring. Thank you very much for your kind attention. Thank you.